Talk about an absolutely bonkers week. In addition to having a new Secretary of State for Health and Social Care, well, we've also potentially going to have a new Prime Minister as well. We've had loads of other stuff happen in the past week that you absolutely need to be aware of, including stuff around the COVID vaccinations, the aspects of basically the amount of underspend in the ARRS updates, and in addition, getting a note from your doctor for travel. This is an episode you're not going to want to miss. Eid Mubarak to all my brothers and sisters out there as we tech enhance your primary care and learning. Hello, everybody, and welcome to this episode of eGPlearning with myself, Andy, Gandhi, and we've got Andy as well. How are we doing there, mate?
Hi, I'm good, thank you, Gandhi. Eid Mubarak. It's Eid, isn't it? So you've had a lot on, I gather.
Yeah, it's been busy and stuff, and definitely lots to cover as well in this episode as we crack on, basically talking about all the changes that have happened in the past few weeks. And there's been a fair few, hasn't there?
Yeah, so I guess just giving an overview of what we're looking at today. I think the big thing that's happened, there's been a lot going on at Westminster. Obviously, Boris Johnson has resigned, so I'm sure there'll be all sorts of opinions on that amongst the people watching the show. Prior to resigning, he appointed a new health minister because we had resignations of the Chancellor and of the Health and Social Care Secretary simultaneously. That sort of sparked this whole thing off. So we'll be talking about the new Health Secretary, Steve Barclay. And then we're looking at some of the other issues that have cropped up over the course of the week, including the autumn COVID booster campaign and the deadlines around that, around how well we're spending the ARRS funding in primary care networks, and a significant proportion can and is often left on the table and unspent. And then some interesting developments in the airline industry around requiring letters from GPs. So yeah, where do you want to start? Where do you want to kick off, Gandhi?
Well, first of all, if you are celebrating Eid like myself and watching this live, do give us a thumbs up in the chat. That'd be awesome if you could do that. But I guess the best place to start is with our new Health Secretary, Steve Barclay. Yeah, it'd be nice if we can know a little bit more about him. What do you know, Andy?
So I didn't know much about Steve Barclay before this week, although I think I have heard his name on the news a number of times, but I've just been having a little look around the internet just to pull together some information so that we can talk about him this morning, Gandhi. So this is Steve Barclay. Steve Barclay has had a number of jobs, and just sort of working backwards, looking at some of his previous jobs in government that have led him to this position as Health and Social Care Secretary. So most recently, been the number 10 Chief of Staff. That's been interesting. It's been an interesting time to be Chief of Staff at number 10, I gather. I think Steve Barclay has been considered to be a fairly loyal sort of supporter of Boris Johnson, hence getting this job in the dying days of Boris Johnson's government. Prior to that, he's been Minister for the Cabinet Office and Chancellor of the Duchy of Lancaster, which I think Michael Gove has also held this position in the past, which I think is sort of a historical position that gets you a seat in the cabinet. These duchies are I think they're pots of money that often fund certain members of the royal family, I gather. So it's an interesting post. Prior to that, he was Chief Secretary to the Treasury. So that's quite a big job at the Treasury. So we'll have some experience of knowing how difficult it is for departments to get funding and the lobbying required for them to get funding. And prior to that, he was Brexit Secretary, which I think is where I most know his name from. So interesting. How well do you think those jobs set him up to be Health Secretary, Gandhi?
So he knows about money, knows about the challenges of working under a strained system and significant change and uncertainty, I guess, with the Brexit side of things. I guess that kind of sets him okay for understanding health, but I didn't hear anything about understanding health in there at all. So it'd be nice to know how he's perceived in terms of that. And I can see you've got some stuff on the screen about that as it is.
Yeah, we've got some bits and pieces. Yeah, but I mean, he's quite an experienced politician by all accounts and by the look of things. Might be helpful just to look at a bit more about his background. So apparently he's from a working class sort of background. He's not privately educated, and from I think his dad was a trade union worker, for example. So I think that's quite interesting that he's come from that kind of background. He's been a soldier. He's been a second lieutenant in the Royal Fusiliers. So that's interesting. And then after that, I gather he then studied for a degree at Cambridge, and then he's worked in finance in the City of London. And then he became an MP in 2010. So he's been MP for the last 12 years, and it's North East Cambridgeshire. is his seat. So
Okay.
that's interesting. And then, yeah, I was trying to get an idea of how he might behave as health secretary. So I was looking for some articles or help on that. And there was quite quite an interesting article in the Big Issue actually that attempted to look at his background and look at that, and they
Mhm.
looked at some of his voting record. So I'll just give you some of the highlights and then show you an interesting tool that they link to in this article where you can look up your own MP's voting performance and profile.
Okay.
So voted against abortion on the grounds of sex selection in 2014. Interesting, make of that what you will. Abstained on a vote to improve
So can I
access.
just clarify, Andy? Do you mean he voted for people to have the right to abortion, or for people not to have the right to abortion?
So this is to clarify that it was illegal to terminate a pregnancy based on sex, because I gather at
Okay.
that point the law, when it was originally written some time ago, didn't
Mhm.
make provision for saying that that specifically was wrong. So
Okay.
this was a vote to clarify that, which people have different views on abortion. That sounds sensible to me in terms of clarifying that.
Mhm.
Abstained on a vote improving access to abortion in Northern Ireland in 2022, I think. So I think that was there was some controversy recently around abortion in Northern Ireland, and that's his voting history on that. Voted against assisted dying in 2015.
Mhm.
I remember there being quite a lot of discussion
Yep.
around that, and we had sort of a special discussion, our local RCGP
Yep.
chapter around assisted dying to sort of contribute to that debate that happened at the time. Um, and then he's voted against restricting the NHS's ability to serve private patients in 2011 and 2012. So I don't know if you remember, this was a bit of an issue, obviously back then, 10 years ago. And I think there was some talk that if people went private for part of their care, that they couldn't then return to the NHS to complete that episode of care for the same illness. And there was some
Mm.
concern people might get a private diagnosis for a cancer and then not be eligible for cancer treatment on the NHS. So he voted to clarify that they could come
Okay.
back into the NHS for treatment, which again feels quite sensible to me. At least I wouldn't want people to be, without that kind of care on the NHS. Particularly, people often just make that initial move into the private space to sort of speed their access to diagnostics and so forth. So,
Mhm.
um, yeah, so that's that. So, any comments on that, Gandhi?
Mm, sounds okay. I do
Yeah,
remember hearing about some interesting comments he's made in the past about the NHS. I don't know if you found any of that in your journeys and stuff.
tell us about what you found, Gandhi, or what you
That
remember.
very much he's felt that the NHS spends a bit more money than it needs. That's the banker element of him, and unfortunately, I can't remember the reference, so apologies if I've got that incorrect, but that is something that's been mentioned to me in passing and stuff, that his views that the NHS is wasteful in its money's use and stuff, and therefore there is that concern, I think, with some, with that he is planning on restricting the budgets, or, limiting the budgets, or potentially even reducing the budgets of the NHS, with a view to obviously the spend of the entire country's budgets and things.
Yeah, so I was looking. I'd got the same sense of his views as well, Gandhi, and I
Mhm.
was looking for the evidence there, and it may be out there, but I wasn't able to find it this morning. But I got a sense that he's somebody who advocates for efficiency
Mhm.
in the NHS. So it will be interesting. I mean, often people's opinions have to change when they're confronted with realities, but we'll
Mhm.
see how that goes. Then Gandhi, I just thought I'd show you and the viewers just an interesting tool that I've heard about before but never used, but been using while researching Steve Barclay. So there's a website called They Work for You, and this enables you to look up your MP, or in fact any MP,
Mhm.
and you can look at a profile about that MP. You can see sort of where they've appeared, where they've spoke, and you can look at their voting record as well. And it seeks, you can look at the full voting record, or it seeks to categorize their voting record on certain issues. So this is some of the information about how Steve Barclay has voted on health, for example. So going back a little bit further, he's voted in favour of smoking bans. This is talking about that vote around assisted dying,
Mhm.
around provision to private patients. So this is that issue about people moving back into the NHS after having private treatment and diagnostics. So you can see where the big issue of research really, and almost always voted for reforming the NHS So GPs buy services on behalf of their patients. So that feels like sort of market reform
Hmm.
in the NHS. What they did note in the big issue is that largely he's voted with the Tory government and sort of been loyal, done what he's been told to do. So it'll be interesting to see now he's got a little bit more power and executive control over health and see what he does with that. Interesting, I looked up Alex Norris. I've met Alex Norris, my local MP, a few times. He may even be watching. He probably isn't watching this morning, but hello if you are, Alex. And it's just interesting to have a look at Alex's votes as well. And I think I'll use this tool a little bit more to
Hmm.
look at what MPs have been up to, and people might want to do that themselves, or even it's always great to engage with your MP, isn't it? Actually, and
Yep.
PCNs are a good way of doing that because often the footprint overlaps um, with PCNs and their constituencies.
Hmm.
So yeah, any I guess we're getting are we getting a few comments in. So let's have a look. I thought previous junior health minister, he may have been. I've not come across that in the fairly superficial research that I've been doing this morning. It would be great if he has been, because that adds to his experience. If anybody wants to clarify or corroborate that, that's great. And then another comment from JC: interesting guy, but questionable. So I guess we've all got sort of questions really about how he'll behave in the new role, how he'll
Hmm.
interact with the royal colleges, with the profession. Yet to be seen. But interesting.
Hmm.
I don't envy the job, Gandhi.
No, so I guess
Being
it's important to talk about his in tray, which is probably one of the most challenging ones to deal with in terms of politics right now. I mean, to be honest, the only job's more complex than his is, well, who's going to be taking over from Boris and the chance of the exchequer, because obviously inflation and finance is a massive, massive headline topic right now. But health is definitely needing direction and support, and he's taken over at a time of absolute chaos in terms of everything else that's going on. So his intro is gonna be scary, to be honest.
Yeah, what would you place sort of towards the top of his intro, Gandhi? What do you think are gonna on day one? What do you think he's going to be
I
looking at?
mean
Um,
we're GPs, Andy, so we're gonna say general practice, aren't we? But actually, I think there's some equally, relevant parts he needs to take focus on. You know, the A&E wait times is constantly in the headlines, is it not? And obviously the wait for paramedics and ambulance crews and stuff because of the significant workforce shortages they're dealing with. You know, COVID is on the up, unfortunately. So, what impact is that going to have? Is that going to, lead to other changes that need to happen within society, or is it, just that we live with it and deal with it, and actually it has a bigger impact on the healthcare service because actually many people are not able to work because they've suddenly tested positive, even though they may be physically well. And whilst they may be able to do some stuff remotely, it still massively impacts services. And at a time when the healthcare service is still overstrained and tired and shattered and not working at capacity with spiraling demand.
yeah, I mean,
There's a lot.
there's a lot going on, isn't there? I know that. I mean, one of our colleagues, sort of senior local GP, that we were both in a meeting with earlier in the week, who I think had the privilege of going down and sitting around some of the health and select committees chaired by Jeremy Hunt, who might be a leadership contender
Mm,
potentially, and he was saying that all the MPs generally hear about from their patients is access and
yep.
access to their GPs. So that is really, really high up on the agenda for MPs as they look at health issues, because that's the noise that they get from their constituents. So that's really going to be up there along with all the other things. And then I guess there's all the things in the background around workforce retention. I think there's going to be calls for inflation,
Mhm.
matching pay increases, and with the potential for industrial action coming into the tail end of the year.
Yep.
Um, it's going to be really difficult. And then I guess the country has sort of somewhat challenging demographics going forwards, in terms of increasing aging
Yep.
and illness within the population associated with age. And then I guess what we can't forget is that social care and health were merged into one department
Mhm.
back in Jeremy Hunt's time. So he is also the Minister for Social Care as well as health. And there's a whole raft of challenges facing the social care sector as well, around keeping standards up, levels of funding, levels of staff pay,
Capacity.
capacity, staff recruitment, retention, in a world where other industries, are increasing pay or having to increase pay. Is there the capacity within the social care industry to increase pay? Oh, gosh,
Yep.
yeah, difficult job for this chap.
Yep. And I think
Yeah.
important to remember a lot of this has been compounded by the fact that officially ICS has took over the responsibility for a lot of the commissioning of healthcare as of a few days ago, which is if you're thinking about a change in leadership, it's possibly the worst time to have something like that happen. When you've got a change in, significant change in the structure of the whole healthcare system, that he's now, somebody new coming into it, having to learn the ropes very quickly as to what he needs to think about and stuff, and what impact is that going to have. Um, but yeah, it's definitely a challenging job in its normal day. Right now, I don't envy the task that he's got to have, but I think, absolutely what I would say to, Steve Barclay is that, speak to the grassroots. Don't just listen to, big fancy corporate consultants and stuff, because actually they will only give you part of the picture, as we know. And actually, if you need some, genuine grassroots opinions, I guess me and Andy are always willing to try and give that to you. So you're more than welcome to jump in and join us in clinic if you want. I've made that offer,
Join us on a Saturday morning live.
yeah, well, yeah, exactly. But join us live here, or you can join us in clinic if you want to. I've yet to see a health secretary take us up on those offers, but you never know. He may be the
Yeah.
first.
You're right,
Which
but I'd like to see the Royal Colleges obviously reaching out to him and him reaching out
absolutely.
to them and the BMA and other representatives of the health and social care profession and other professions within health, because he needs to think about the voices that he's listening to and making sure that
Mhm.
he's not just listening to one side of certain arguments around privatization or funding and so forth, and make sure that he's getting good information from a wide variety of sources. And I think that's what any good leader does. And I hope that he does that. Just to provide some clarity, so just get back a little bit further than we went with his jobs and going backwards in time. So prior to being Brexit Secretary, he was a Minister of State in the Department of Health and Social Care. So there is some health experience there.
Mhm.
And Economics Secretary to the Treasury. He was a government whip. He was prior to that, he was an assistant whip, and then he sat on the Public Accounts Committee, and that takes us back to 2010 when he was elected member of Parliament in East Cambridgeshire. So that's him. Any I'm thinking about my wish list for the new Secretary of State. I think top of my wish list, I think, would be don't do anything radical because I've got a feeling he might not be there for very long. That being said, somebody from his wing of the Conservative Party might win the leadership and he may be there for longer. But
Mhm.
perhaps in the immediate future, just sort of steady the ship, continue with the plans are already afoot. There's a lot of change going on anyway. And don't do anything radical for the next 3 months would be top of my wish list. After that, for the next new permanent Secretary of State for Health and Social Care, I've said before that I would love more independence around the statistics that we use to make health policy, about
Mhm.
the statistics around the number of people in the workforce, about the impact of policy as well. And I've been really impressed by the Office of Budget Responsibility, that is a government-funded independent department that provides an assessment of the impact of the budget each year when it's released, which avoids the sort of massaging of figures by government and by ministers, and provide something that they have to acknowledge as being factual in terms
Yeah.
of the impact of their policies. And I'd love to see something very similar for health. I think it would be a bold health secretary that puts that in place to improve the policies that we have driving health, not just the delivery. So that's
Mhm.
that's my wish list. Anything on your wish list, Gandhi?
Transparency, honesty. Let's be honest, the health service is in dire straits. And instead of saying, "Yeah, we've got a world-beating NHS that can do everything and do everything for everybody all the time," let's be honest, it is struggling, and stop flogging a dead horse effectively, because that's how it feels to many on the ground. And unfortunately, we're seeing that in terms of workforce retention, just literally dropping like a lead balloon, that people are leaving the profession in terms of general practice, but also in other areas, nurses, doctors within hospitals and stuff. We're not seeing retention of workforce. And if you don't have the workforce, you're not going to be able to deliver a service. And I think, there needs to be that honest, absolute discussion about how people are using the healthcare system effectively and appropriately. And that discussion about what that means for the future of the healthcare system itself, because it can't continue doing what it's doing. All it takes is one nasty winter, and we will be in a worse state than what we saw during COVID. But with the expectations that everything still happens, and there are genuine worries that's going to happen. You look at the Australian flu spike that they're having in this current season. If it tracks through and that comes through to us in September, October time, we're in dire straits, to be honest. Really are. Um, But yeah, it's a challenge, and I think the best way around that is open honesty and transparency, and it's something we unfortunately haven't seen from our politicians lately. So whether
Yeah.
that will happen or not is an interesting point.
There was something you said there, Gandhi, which I've not heard for quite a long time, and that was that people, and Christina's jumped on it as well. So I'm going to bring Christina's comment up. You talked about people using the health service appropriately, and it just struck me that I've not heard that. That those were the sorts of arguments prior to the pandemic, or perhaps a little bit before then, that
Mhm.
we were talking about a lot about actually some use, some demands placed on the NHS are not appropriate, and the system can't do everything for everybody. And actually, at the moment, it seems like we're just like anyone should be allowed to access, their GP or their GP surgery for anything, any time of the day. And it almost feels like we've done a bit of a 180 degree turn on those previous conversations that we were having. I
Mhm.
remember sitting in conversations about should we levy a minimum charge to see the GP. That was maybe 6-7 years ago. It's just interesting how the debate has really shifted in favor
Mhm.
of access for anything, anytime. So thanks, Christina, for highlighting that. Um, Andrew Lloyd suggesting he might apply to be health minister.
Mhm.
Sounds like practice manager, so I'm sure he'd bring some good experience to the job.
Hell,
Um,
he'd probably do the job amazingly with that kind of resume. If you're a practice manager, you can run pretty much anything, to be honest, in my view.
Yeah. And then just a few more comments. John Henderson, like to see some fences being mended between primary care and the Secretary of State, and I
Mhm.
can't agree more. And working together to improve reputation of general practice, which has suffered of late as well. And it feels like it's general practice has been sort of kicked down and been
Yeah.
blamed for things to shift blame away from other issues which are harder to tackle, such as
Which is interesting when you look at
overall
the
issues.
data. So if you look at the appointment data for May 2022, we produced I'm gonna get slightly confused with the numbers, so apologies. The tweets are on my, Twitter profile if you wanna check it, though. I think it's something like 17% increase in, appointments provided in general practice compared to, last year, which was equivocal to what was happening in May 2019. So 17% increase in appointments. So that whole adage that general practice is shut and not doing anything, definitely wrong. Face to face, still slightly under 2019's years, but a massive increase from last year. I think it was nearly 20% increase from last year in terms of face to face contact. So, general practice is definitely cracking on and doing the job. And there just needs to be that acceptance that it can't do everything all the time for everybody because, well, there just ain't enough of us, to be honest.
Here, here. So
And on that note, shall we transfer over to the next thing that we're going to talk about, which is something that's definitely going to be on people's agendas if you are in general practice, the autumn COVID booster. So, this is a fairly specific piece of information that came out just about 2 weeks ago. And it's talking about the fact that there is plans for the COVID booster campaign in autumn and what that looks like and stuff. And an interesting point to note, there is a deadline on this. So the deadline is Thursday. All practices have to give notice in terms of whether they are planning to deliver the COVID booster campaign for autumn by 5 o'clock this Thursday, the 14th of July. And it's really important that the practices are aware of this and that they're engaged in terms of the differences. So there are some changes that have happened in terms of delivery. A lot of the stuff carries on in terms of the option for delivering it as PCN groupings, the rules around vaccinations and stuff. But the letter in particular is probably worth looking at as the summary because the main document is complicated and broad. But the key thing changes are the fact that number one, there is a reduction in the item of service charges practice will get for delivering the COVID vaccination. So it goes down from £12.48, I believe it was, to £10.06 per person. And with an additional £10 for housebound patients if you're delivering that. The other additional thing to note is that there is absolutely the recognition that if you are delivering this, this should be business as usual. That you can't say that you're delivering this and not doing other stuff. So, obviously there has been a priority placed on vaccination of patients in the previous campaigns, particularly over last winter and stuff. That will not be the case moving forward. In any area delivering the COVID vaccination must also be able to deliver business as usual. Um, there is an element of general practice in particular, focusing on three key groups. So those patients in care homes, those housebound patients, those patients that are immunocompromised in particular. And there was definitely something else that I've forgotten.
yeah, and there was just I think this is fairly standard, but the PCNs need to be in a position to start talking about how many vaccines they'll be able to deliver each week to assist in local planning at CCG, ICS level. Yeah, so
And
Gandhi, how
important
do
to
you
note
see
that
it?
that number will be used to evaluate you against. So if you say we're going to deliver 300 vaccinations a week, there will be the absolute expectation that you are delivering 300 vaccinations a week. So it's not that, well, we could do this. No, they want to know the absolute number that you can and will deliver on, because there will probably be some element of evaluation to say, well, why are you not doing the 300 that you said you do?
Yeah, it's not talking about capacity, is it? It's talking about delivery. So it's
Yeah.
actually getting the people in, recalling them in, and doing them, which I
Hmm.
think is an interesting use of language. There's a good table at the bottom of the letter just so that you don't miss any of the deadlines coming through. And obviously, there's some information there for pharmacy-led clinics as well as
Hmm.
GP-led clinics with slightly different, but actually very, very similar
Hmm.
information. Gandhi, what do you think about the reduction in costs? Do you think it's still going to be cost effective for general practice in most circumstances to deliver this? Would you say?
So I assume this is because it brings it in line with other vaccination costs in terms of how much we get for delivering the flu vaccination, and that's partly because the startup costs probably are not thought to be necessary compared to obviously when we were delivering this for COVID vaccinations. The original time, there's additional startup costs in terms of how you look at doing that. So that was to incorporate that. Important to note that there are some other aspects you need to be aware of. So I did remember, and it's in the first paragraph of those key changes. Number one, that you have to have the ability to deliver any vaccine you get. So important to remember your staff needs to be trained to deliver potentially any vaccine, whether that's Pfizer, Moderna, AstraZeneca, whatever it is you get. You need to be able to have the educational abilities and capacity to deliver those particular vaccines. And there's no information as to what you may be getting, and that may change on a weekly basis as well. Also, the ability to match surge capacity. So if there was felt there to be a need in terms of the excess vaccinations needed, you have to be able to respond to that as well. And I think this is the key part that I have slight issue with. It's asking for a commitment to deliver it by next week, with about 3 months to go following that point. There is no understanding of how this is going to work with flu, which is obviously the other element of campaign that happens. There's no guarantee that you'll be able to have the vaccines in a point where you can co-administer, although that is the hope. You'll be able to co-administer both vaccines at the same time, so then you're not having to call patients in twice, which obviously from a capacity point of view is definitely the better way of delivering such a campaign. But the logistics of making this work, yeah, I'm just concerned that there are going to be some areas that potentially signing up to this which don't understand the implications of what they're signing up to, and that actually it's a real challenge potentially because we have so little known information about what we are being asked to deliver and stuff. So I think there's some real challenges here, and I think each individual practice really needs to consider, what this is going to impact in terms of, because of that key point of you must deliver business as usual. You know.
Mm.
I
So
don't
do
know
you
what
think?
your thoughts are, Andy.
Yeah, I'm wondering if for many primary care networks, they'll have expended a great deal of effort getting their systems in place and up and running, and actually, this may represent a continuation of business as usual for many primary care
Mhm,
networks. Hopefully, they've got to a position where they're delivering business as usual and some additional vaccine capacity. Although it's difficult because you need the staff to do it, and those staff previously would have been working in another part of general practice or the healthcare system in general
mhm.
most of the time. There has been ability to bring in, volunteers and and other people and train up people to do the vaccines, I guess. But yeah, I think for most people, is it probably going to be business as usual in most places, or am I being too optimistic?
Important to note, so that extra workforce you mentioned, that unregistered workforce, they're not allowed to be part of this anymore. There is a specific line that says that you must use registered workforce to deliver this as
That's
well.
true.
So you can't lean on those additional volunteers, those people that aren't registered. So, the capacity
Yeah.
for things like HCAs and PAs to deliver these vaccinations, because they are technically unregistered in the concept of they are not, they don't have an organizational body and stuff like the nurses, like the GPs, those kind of roles and stuff. So they may not be. I haven't had a chance to go through the detail, but in terms of consent, they're not able to consent patients. There is something in the detail about that you have to be a registered practitioner to deliver the consent for patients. And in terms of drawing it up as well, so it does need to be pharmacists and roles that are registered that can draw up the vaccines. And that is a subtle change in the documentation, as far as I can understand. I'm happy to be corrected on that if I've interpreted that incorrectly. but important to know that does impact the capacity of practices and networks and stuff to deliver that if they were relying on volunteer workforce to help, which is part of the reason why the campaigns were so successful, because we had such amazing dedication from volunteers in addition to the absolute grit and commitment from general practice.
Yeah, had a few comments again as
Go
well.
for it.
I don't know that we know the answer to this one. Care home patients are not included as housebound. I think I know previously they were, so it might be that the rules have changed
Not
here.
sure on that. We need to check the
Would have to
guidance.
go back into the main
Yeah.
document. But thanks for raising that, John. That will be problematic if that's the case. I think.
I'd be surprised if they weren't, because by definition, if they're in a care home, often they are housebound patients. So, mm,
They normally are, although not always. They sometimes come for appointments at the surgery, and we
true.
always remind our care homes that that's definitely a possibility with them, and good for patients a lot of the time as well. Um, some comments around hoping that the item of service would not have been dropped there, although business as usual. Christina says BAU, assuming that's business as usual. Christina. Um, any info whether we need to use Pinnacle? I think there is a requirement to record the vaccine on the same day that it's issued, and I think
Yep.
Pinnacle is quite embedded into the
Although
vaccination.
there are other
No,
systems, I remember, Eva for
you've
Healthcare was
spoke
an
about that, yeah.
amazing system that, allowed and really effective use of this and was licensed for using for vaccinations towards the tail end of the campaigns, and some areas are still using that as well. So, there are other systems, but yeah, Pinnacle was the lead one because obviously that was the initial one that was used by most areas. And thanks to Christina, apparently she's confirming that, yep, correct, it is care homes are not included. That's really interesting. I hadn't picked up on that, so thank you for that, Christina, for that in terms of the detail and stuff. But yeah,
Yeah.
important to note that there is a deadline for this for practices. This Thursday, you have to have notified whether you are planning to join in terms of delivering the COVID autumn booster campaign, and obviously the potential impact that's going to have on your local practice areas and networks and stuff. And then obviously, if not able, then I believe the responsibility falls to the ICS to look at how that's delivered and stuff. So interesting.
So next story. So this is a story sort of picked up in Pulse. 40% of ARRS funding unspent in the first 2 years of the scheme. So this is it's an interesting article. I don't know if this should come as a surprise to us because we've spoken of the difficulties of spending this money on the podcast before.
Hmm.
So these are figures obtained by Pulse under a Freedom of Information Act request. So they've been writing to CCGs, ICSs to ask them to report on their figures, which
Hmm.
is very sensible, and it means I think we can trust these figures quite a lot, actually. They've summarized them in a nice little table here, actually, just highlighting some areas and highlighting their underspend. And I guess these are probably some of the areas with the biggest underspends, but highlighting in year by year. So 2019 to 2020, there was a budget for ARRS staff of 62 million. You can just see how the budget is increasing for those
Hmm.
ARRS dramatically as we go over time. Lots of new resources coming in to general
Yep.
practice and primary care, represented by that budget to spend on those specific types of staff, highlighting their spend and the underspend. And that 2021, which is the figures that they're picking on as 40%, although that improved in 21 to 22, but they've not put that in the headline there.
Hmm.
So really, really interesting. I think what strikes me about this is one, actually the amount of money and how it's increasing coming into ARRS staff, and actually the amount of money that's being spent and how that's actually increasing a lot
Hmm.
as well. And in some ways, people have been quite successful in spending the
Hmm.
money and and ramping up and getting new jobs and roles and services online very quickly, because it's a really big ask to set up a social prescribing service and a clinical
Yep.
pharmacy service across a primary care network and a health and well-being service or dietitians or whatever you're doing to meet the needs of your local neighborhood population. There's two ways to look at this, really. In some ways, it's probably been quite successful. It
Hmm.
also doesn't say whether this is after the money has been put out for people to apply for again. So I know
Yep.
in many areas, the underspend is then offered up for people to make specific bids against to spend again. And it's not quite clear to me
No.
whether this is after people have had the opportunity to rebid for the underspend. So
Yeah, so just to explain that to those people who don't know about how primary care finance and particularly PCN network finance works, each year the networks are allocated a set amount of budget to use on additional roles. So that's things like the PAs, physiotherapists, pharmacists, social link workers, health and wellbeing coaches, all the roles we've talked about in previous stuff and things. Whatever's not used then gets rolled into a local budget that they can potentially reallocate to networks over the following year. And if it's not used, then there may be some underspend is the term that still can be used either or returned back to NHS England because it's not been spent and stuff. And I think that's what this article's focusing on is that underspend element of stuff. But we don't know if that's the underspend at point one, where the networks have not been able to use it, or point two, where the local area has not been able to use it and stuff. And that's sort of the question raised by Christina in her comments: is there any data on the shortfall sums that have been reinvested / spent? I don't think we can see that kind of data and stuff, can we, Andy?
no, I don't. It's not clear in the article whether this is after reinvestment of the shortfalls, but it's a very
Mhm.
good question. That's what we were thinking as well. Thanks for the explanation of just what the ARRS funding is for those people who might be joining us for the first time. You know, it's money, new money for general practice that can only specifically be spent on certain roles, and those roles work across a number of GP practices that
Yes.
represent a specific community, making the
Very clearly, it could not be spent on GPs and it could not be spent on nurses. So
yeah.
those people are thinking, "Oh, well, they've had loads of money to spend." No, actually, those are the 2 roles we're not allowed to spend the money on at all. But it's interesting to see that there has been an underspend. I mean, does that surprise you at all, Andy?
No, it doesn't. I think there's lots of difficult. I mean, PCNs started from a standing start and had to create, a new organization effectively,
Mhm,
encompassing those GP practices, that was able to bring new services online, employ people, and bring those services to patients. I think there's a number of challenges, isn't there? I mean, people talk about the lack of flexibility in this funding. You know, it
mhm,
can only be used for specific roles, and those roles are not necessarily the roles which we were crying out for in
mhm.
2019. So I think there's a lack of flexibility there. A lot of areas I think have found that whilst they intend to employ a certain number of clinical pharmacists, they just can't recruit them. You know, they're just not there because every primary care network up and down the country is wanting to recruit clinical pharmacists and social
Yep.
prescribers, and health and wellbeing coaches and nutritionists and um, mental health workers and paramedics, and they're just not there in many areas of the country. And then I think we're having a number of comments which are echoing these problems. I think somebody has mentioned that they have nowhere to put the staff. So
Mhm.
there is provision for increased space for these people to work out of. So some people are just butting up against the hard physical limit of the space they have to put people in. There's all sorts of difficulties. I think somebody also mentioned supervision as well, or hinted that these staff require onboarding, training. They often require the supervision of more senior staff, which is often
Mhm.
GPs, and there aren't any more GPs provided for by this
Yeah.
funding. So there's sort of a supervision bottleneck and a management bottleneck as well, because it took time to get network managers um, established as a concept, even in some
Yep.
areas before they were brought online to help manage these new staff. So it doesn't
Especially when
surprise
that
me
was
again that
under-resourced as
they're
well,
underspending.
so that wasn't part of the resourcing in terms of, how you manage the staff and stuff. There was potential pots that could be used, but it was never directed to in that sense and stuff. I think, like you mentioned, it highlights the challenges we faced. First of all was the workforce availability in terms of having people to hire. Second is the supervision element that comes into play that many places really struggle with, and then absolutely estates. Some places have space to put these members of staff, some places just don't because there's no space and stuff. And then it's understanding how that all combines together at a time when COVID kicked off right at the start of it and massively diverted the attention of what people were focusing on for delivery of care. And that's why there probably was that in that second year, that massive shortfall of use because people just didn't have the headspace to focus on this part of delivery versus the COVID efforts. And then obviously the vaccinations. That may also be why it picked up afterwards because actually there was a recognition these AR staff can help out with the vaccination campaigns, can have benefits, and actually people had a little bit more headspace and time to focus on cracking on with the job from my perspective.
Mm,
But yeah.
yeah. Yeah, you're right. It's 20 to 2021 was right in the middle of the pandemic. I mean, it's no surprise that recruitment was difficult in
Mhm.
that period of time. Um, uh, Christina and John continue to provide some really really good comments. Actually, it's almost like Christina's looked at our show notes because we were going to talk about how can we improve, and we said be creative, and there are specific roles like the care coordinators which actually can be deployed to a number of different applications just to help coordinate the care there. So those are really, really good suggestions from
Yeah.
Christine. I also think the social link working prescriber role can be quite flexible as well, and
Mm.
I think areas can be quite creative in general. Something that I've seen locally that hopefully will work well is actually um, creating social prescribing roles around services that are established and enabling them to bring on more staff to apply to quite specific problems people have. So we've got the concept locally of financial
Yeah.
social uh, social link work prescribing, and actually, local organizations already have expertise in providing financial advice to patients in difficulty where that's affecting their health, but they don't often have the funding to increase
Yeah.
their headcount. But they can bring that member of staff online, pay them and train them really, really well, or use it to maintain the position of an existing member of staff that might lose their job. So I think there's lots of opportunities to partner with
Mhm.
organizations as well. And I think there's been a process of discovering what's allowable, what isn't, what works, what doesn't, that is continuing. So being creative, I think, is really, really important.
Mhm. So, no surprise that there's a bit of a shortfall. It'll be interesting to see what happens towards the end of the PCN DES contract and what that means in terms of what happens when there's a shortfall on the year 5 funding, because it is significant. Most networks will have, ARRS budgets of over £1 million potentially in terms of use and stuff. So, definitely be interested to see how this continues to develop. And we are seeing lots of change in terms of ARS staff as well, in particular in some areas. So, people moving from either role to role across different networks and stuff, or more importantly, as we mentioned earlier, people are just leaving, to be honest, because it's so challenging right now in the healthcare service that actually where we see higher levels of underspend in this financial year, I think it'd be really interesting to find out, because actually I think there's going to be a lot of shift that makes it challenging to understand that and stuff. But we
Yeah.
shall see.
Gany, I've got a question for you. This is about what happens at the fifth year of the PCN network, because in some ways you might think, well, they've guaranteed the funding of staff going forwards from that point. Does that
Hmm.
mean that PCNs should staff up, to that point and get as many staff in place as they can, in the expectation that the budget for that staff will be preserved? If you've got an
Yeah.
underspend or an unspent budget at that point, will that be carried forward, allowing you to recruit using that funding, or will that be taken away from you?
It's
I
an
don't know.
interesting thought, isn't it, Andy? And it's a question no one's, as far as I'm aware, has been able to answer. But there is definitely the view that, maximize your ARS budgets, because that budget will be transferred over to responsibility of the ICS to deliver when the contract's over, because that's what they all signed up to as part of the fuller stock take.
Mm.
So we covered this in one of our earlier episodes when we discussed the fuller stock take, that actually all 42 ICSs have signed up to continuation of the PCN DES into whatever funding that they will have moving forward. Now, all the other aspects of PCN funding, like transformation funding, all those other elements, that may or may not continue. We don't know. We will find out. But at the very least, the staffing budgets are thought to be continuing in the new ICS. So
Yeah.
if you're at 1.2 million by the time you hit year 5 versus zero point 0.9 million, what will continue? We'll find
Yeah.
out, I guess.
I think it's a big headache for health equality and health equity if, those
Yeah.
areas that deliberately staffed up get more funding going forwards than other areas. So for
Mhm.
that reason, I sort of can't see it happening, but you do wonder, and it's not
Mhm.
clear at this stage. Um, some really good comments continuing to come through. Christina's mentioning about 3 sittings. That's something we're thinking about as a practice, actually. So 3 clinics in the day rather than 2, to maximize the use of space. We've just converted some cupboard space, if you like,
Mhm.
into a sort of almost like a doctor's sort of ready room, like we used to, like we used to have off the ward in
Yeah.
hospitals, where doctors could do paperwork or make telephone calls. When they don't need an actual clinical room with a bed and with a floor that isn't carpeted and so forth. So I think, yeah, need to be creative. Last line
Well,
there,
I've
really,
often
really
postulated to
important.
many in primary care that there are these devices you can have, like the room and that kind of stuff, which are encapsulated workspace offices used in many places, like remote working and that kind of stuff. Actually, generally speaking, to do clinical admin and stuff, you do not need a clinical room. So why not use that? Save space.
Just need a noise cancelling headset to make telephone calls. You can do it
Exactly.
around other people. Receptionists take calls in busy areas all the time, I
Yep.
guess.
And John Henderson mentioned PCNs are evolving into primary care organisation, a lot like GP practices, though without the legal entity. Absolutely. liability is a part of this, isn't it, in terms of responsibility? I think that's one of the interesting things that we've heard also from various discussions, that the responsibility of delivering healthcare is a little bit uncertain with the whole ICS shift and stuff. So what does that mean moving forward? Who is now responsible for delivering healthcare?
Hmm.
Interesting question. But we're going to
And
talk about something else now.
time for the last story. So,
Yeah.
Gandhi, this caught your eye.
Yeah.
It's sort of up your street, in a way. EasyJet requires GP note explaining medicines in travelers' luggage. So, tell us what this was about.
So first of all, it's a lovely sunny day. The day we're broadcasting, it's one of the warmest days that we've had on record, and we're apparently about to hit into a heat wave. So obviously, summer is hopefully coming. Many people are probably thinking of heading off on the airlines and heading for sort of sun abroad or home or whatever and things. And it's an interesting time for the airlines to suddenly start changing their policies of what they want to do. And this one particularly focuses on EasyJet mentioning that if you are carrying medications, that you will need a letter from your doctors, they could term it, to explain why you need those medications as you pass through airport security and stuff. Specifically mentioning liquids over 100 mils. And they say this could be a letter. They do say it can be a copy of your prescription. So that's possibly an easy out for many people. Just simply get a copy of your prescription, the counterfoil from the pharmacy that you would normally get your medications from. They can easily print that out for you and stuff. Or better option even still, just register on the NHS app and you'll be able to have instant access to your repeat medications through your practice, because actually all practice should be able to enable that for you automatically and stuff. However, the prospect of having a note from your doctor to say these are the medications I am on, actively done by the practice, let's be clear that this is not a good idea, because it's contacting your practice when they're already trying to do loads of amazing things for your healthcare. We talked about the challenges of vaccinations and various other parts and stuff, and getting a request to have a letter to have your medications is not an effective use of general practice time. Definitely should not be done by the GP. At the very least, the practice admin reception team can be doing this. So if you're booking an appointment to get this letter, please don't do that. Please, 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 please don't do that. Was that enough pleases, do you think, Andy?
I think probably not. It does put patients in a difficult position, though, doesn't it? Because I often have these conversations with patients, and they're being told to go on their holiday that they've not been on for multiple years, that they need this paperwork in place, and it's really difficult, isn't it? When they are told that it's required. So I know that the BMA have got involved, and I think that's the level at which we need to get some resolution to this, and just make sure that EasyJet understand the effect that having this sort of policy will have on general practice, and understand that actually it may not be necessary to ask for all of the detail they're asking, and that actually they can get useful information and sufficient information by just allowing people to produce copies of their repeat prescription or documents that already exist or are generated through the general activity and engagement with healthcare services. Yeah.
I mean, this speaks to me in the it's parts of other things that have happened recently. So many people on social media may remember about a week or so ago how the NHS.uk, part of the social media platforms on their Facebook and Twitter profiles, advocated for patients to go see their GP for travel advice. Now, interestingly, they specifically mentioned go see your GP for travel advice. Let me be very clear. The GP is often the worst person in the practice to see about travel advice, because they delegate all that responsibility often to their practice nurse, and some practices actually do not even offer travel advice, because they may not be doing that themselves in-house. So actually booking an appointment with your GP to ask for travel advice is, again, one of the worst effective ways of trying to manage both your time and the practice's time, and takes away care from patients who need it. There are absolutely better options in terms of looking online. There's the Fit for Travel website, which is amazing at giving advice. But often practices will have their own in-house way of delivering that advice, often, as I mentioned, through nurses or pharmacists that will be able to do that far more superiorly than the GP. But I think this speaks to that absolute recognition that many people do not understand how general practice works, and actually asking a GP to do everything, having a GP letter to do everything, is the wrong way to seek your healthcare. And organizations like NHS UK, who should know better, let's be clear, that's the reason why it was so awful, is that NHS UK should know better. But absolutely, private organizations like EasyJet saying go get a letter from your GP is awful advice that they are giving. because it doesn't understand the fact that they've just, in my view, that they've just kind of put this out. They haven't even done any kind of work to understand how things are meant to happen and stuff. And obviously, may lead to conflict. That may lead to cost to patients because a letter from your GP is chargeable often. You may not think so, but if you're asking for a letter, a specific letter outlining your medications, that is not NHS service. That is a potential cost that will be attributed to you. So unpleasant discussions and surprises for everybody on board. I'm ranting now, Andy. You need to stop me.
Stop. Now, I was going to say in danger of ranting myself. It's the classic example of GPs acting as the risk absorbing, risk sink, sort of risk function for other areas of society, isn't it?
Mhm.
People can, they can offload some of their risk around, medical risks around flying by asking for medical certification confirming fitness to fly from
Yep.
GPs or other health professionals, and that removes a risk which they would have to carry and would have a commercial cost to them in terms of things going wrong or insuring
Mhm.
against that. They just shift that entirely to a tax-funded, socially funded part of the NHS, without paying for that, which feels very easy for them at EasyJet.
Important to note, GPs should never be certifying somebody fit to fly as well. It's outside of their competencies to do
Yeah,
so.
yeah, we're not
So that is
aviation medicine specialists.
yep,
Um,
so that is meant to be a specialised clinician with aviation-based medicine training. That's not your GP. So if your airlines are saying that you need a letter from your GP to say that you're fit for flight, that does not exist. So
Gandhi,
please do that.
few people have mentioned an easy technological fix potentially. Mentioned, can we use the NHS app for this sort of thing? And then, how would that work? And that sounds fantastic,
Yeah.
really. And I remember in the early days of the NHS app, they were talking about the evolution to, allow other apps or services to plug in or allow people to selectively share information from their medical record in a trusted way with other organizations. And this would
Mhm.
be a great example of that, really. If you could, choose to share your repeat prescriptions and maybe certain aspects of your health summary with, certain organizations, that would be ideal, wouldn't it? And we've had some
Yeah.
experience with the COVID passport, the COVID vaccination passport that generates a QR code. I mean, wouldn't it be great to have a health passport in general that pulls out health relevant information in your repeat prescription, and you could share
Mhm.
that on a one-off basis with organizations like your airline, one-off time limited basis, using a QR code or something like that. That
Yep.
sort of thing would be superb.
And potentially that will be viable absolutely once advanced or prospective access, whichever name you want to give to it, when patients have complete access to their medical records from, I mean, they have it now, let's be clear, but in terms of the national requirement to do that happens, there are obviously concerns about that process, as we've talked about previously. But I'm going to pick up on one particular comment. So it's from DM. Love the avatar picture, to be honest. I wish I looked that good, to be honest. But yeah, how would the NHS app as evidence work? So let's be clear about one thing. So the NHS app, in order to register to use the NHS app as you as an individual, has a security process which is akin to passport level. It's not quite at that level, but it's as close as you can get without being, the level of certification and authentication you need for your passports and stuff. So it is individualized to your medical record. So if you have access to it, that is your medical information that you're sharing. And through the NHS app, if you have any regularly prescribed medications through your practice, it should be visible as long as your practice has switched on the patient level access, which majority of practices have done and should have done, to be honest. There is sometimes a process that needs happening in the back end for some practices to make that happen for individual patients. And there may be some patients where access to that information is not appropriate. It's very limited in that situation. It's often things like safeguarding or capacity issues and that kind of stuff. But that's how you would access it. So if I was on regular repeat medications, I could literally pull up my phone and show you. I'm not on anything, so unfortunately I can't. But through my NHS, I can see that. I know other people in my family. They can look at their medications if they want to through the NHS app and stuff, and patients can do it. You can even request your medications through the NHS app, which is what I recommend to most of our patients. Then you've got complete control of your healthcare, and not having to rely on other people to do it for you. So yeah, it's a great system for doing it and would be the absolute best way to do it because all you simply need is your phone, which obviously the question comes, what if you don't have a phone? What if you don't know how to use technology? Well, the app is fairly basic to use. And I think, like you mentioned, the vaccination elements of the COVID vaccination certificates and stuff have massively, I think, upskilled majority of the population. For those that don't have that technology or don't have the capabilities using that technology, as I mentioned earlier, simply get a copy from your pharmacy. Done. Dead easy to do.
Excellent. Gandhi, very opportune question. I'm just wondering, on the EGP Learning YouTube channel, is there uh, is there a collection of apps around using the NHS app to streamline things? I know there are a lot of resources there. I'm just wondering
Yep.
if we put that together as a um, what do you call it when you bring all the videos together? I've forgotten. What's that called?
Playlist.
Playlist. That's what it is. Yeah. Is there an
So,
NHS app playlist?
So there is an NHS app playlist because, to be honest, there's only one video you need to watch, and that's how to register for the NHS app. Potentially, we're going to have some more content in the near future in terms of using some of the additional functions as they come on board. But yeah, there is the patient. I've forgotten the exact name for it. I can put the links to that down below if people want to. The patient engagement playlist. So it's all the various video content that we created through eGPlearning that's specifically designed to support patients. So on there is the NHS app video. On there is how to send a photo to your GP, how to send a photo of your throat to your GP, various videos along those, how to register with your GP practice, and other content as well. So if you want to access any of that, we'll put the links to that down below. Alternately, there are other ways we can get to that, and what I'll probably do is stick the playlist somewhere here at the end of this video. So if you're watching now, do check out in a second. You'll see that coming up in the middle in a few seconds and stuff. But before we get to that, we had some more questions and comments. I think where we've got Andy. The practice should be adding as a hospital only as a repeat so it can show the patient's medication list.
Yeah, so it means when something's provided
Oh,
by the hospital only, we should be
mhm.
adding that, which we should be doing, but you sometimes see that not done actually.
Yeah.
And that can provide a bit of a blind spot in that patient's medications for the GP and other people who engage with the
Mhm.
GP record. So that's really, really good advice, and we all need to get better at doing that and knowing how to do it because it can be
Yep.
a little bit fiddly if you've not done it before,
Again,
depending on.
videos for how to do that on System 1. Yeah, check out the EGP learning list and stuff. We've got all that information for you. But I think, there's lots of stuff that can be done to help with this kind of process and stuff. And I think, what really frustrates many of us is that instant kind of knee jerk of go to your GP to do all this stuff. And what we're trying to get across is you do not need to do that. Important to note, some countries do have restrictions on certain types of medication. So even if you're prescribed them, you can sometimes get caught foul of the rules and regulations there, and particularly in terms of volumes and amount that you have. And also to remember, important to remember that general practice will often not provide you more than 3 months worth of medication if you are going abroad. So bearing that in mind, since we're talking about travel and everything else, are common challenges we face in general practice and stuff. But hey ho, that's letters for your doctor and by airlines and that kind of stuff. Andy, anything you wanted to cover?
I think what are we? 57 minutes in. That's good. And it's such great weather outside, although I've got my curtains closed. So it's probably time to wrap up from my perspective. But I've really enjoyed this morning, and in
Mhm.
particular, just sort of thinking about the new health secretary and um, almost like a trial run for when we introduce the next one. It feels he might come along in a few months' time, or may not. We may have Steve
Weeks
Barclay for
or
longer.
days, who knows? Yeah.
Let's wait and
Well,
see. Unpredictable.
yeah,
So yeah, so I've had a really good morning. It's been great to have so many comments from people
absolutely.
watching the show today. The engagement's been really, really, really fantastic. So I really enjoyed that aspect this morning.
And if you still want to engage with us and send us some comments audio method, then do log on to speakpipe.com/egplearning with a capital G and a capital P, where you can actually send us a voice note of your actual thoughts on this episode or any previous episodes or stuff you'd like us to deliver in the future. We love hearing from our listeners and stuff and absolutely would love to do so. And as always, if you do have any comments or questions, let us know in the chats down below because that will continue. We will respond afterwards. Alternatively, if you do want to check out the video playlist I mentioned, it'll probably be coming up around about here right now, and other content will probably come up around about here from YouTube. And as always, we're here to help tech enhance your primary care and learning, and we will catch you in the next episode. See you later.